sharing. Share. Hello, good morning.
Good morning, sir.
Morning. Shall we start? Today we are discussing about common disease that affects the anal canal. A painful condition where the patient may be suffering a lot. Along with the hemorrhoids, this is another condition which commonly brings the patient to the surgeon. What do you mean by this fissure? Fissure is nothing but a crack in the epithelium, a tear in the epithelium, or a break in the epithelium. So you can see fissures in various parts of the body. You can see commonly fissures on the sole of the foot. The hyperkeratosed skin will break away in the summers in old people who walk barefooted. You can see fissures in the tongue because of the syphilitic infections. You can see fissures at the angles of the mouth. Likewise, you see fissures in the anal canal also. It's a simple break in the epithelium. What is the difference between this fissure and other fissures? Though they are acute painful conditions, they heal in a normal time. A week or so they get healed. But the environment, the ambience of the fissure in anal canal is different. It is continually getting infected from the fecal matter. It is continuously disturbed every day. When the anal canal stretches during defecation, the figure is disturbed. And the skin here is surrounded intimately by a muscle which goes into spasm and causes a lot of pain. Because of these different circumstances where the fissure is present, this fissure takes a long time for healing and cause a lot of discomfort to the person in the form of pain and bleeding. That is the importance of the dealing with fissure in the anal canal. Otherwise, it is nothing but a simple crack that can heal in a week or so. So the nomenclature, anal fissure is equal to fissure in ano. In either way you can call it. It is a longitudinal split in the anoderm of the distal anal canal. When it is very well defined, it resembles a cano-shaped ulcer, a long, narrow ulcer, cano-shaped ulcer, which extends from the anal wart up towards the dentate line, but not beyond the dentate line. It never extends beyond the dentate line. It's always below it. It is confined to the anoderm, the modified, stratified, squamous epithelium of the anal canal. What are the causes of this fissure? Most often, it is idiopathic. Only the theories are proposed to how it can be caused, but no definite factor is identified in majority of the cases. And another characteristic is it is mostly in the posterior midline. The fissure is seen mostly in the midline, that too in the posterior aspect. Few cases you can see anterior also. The theories that were proposed are anal fissures arise from trauma of strained evacuation of a hard stool. So if we consider the anatomy of the rectoanum, the rectum will be curving anteriorly and the anal canal will be curving posteriorly. This bend occurs at the anorectal junction. When the hard stool comes down along the rectum and when the intra-abdominal pressure pushes it down, the strain, the pressure falls on the posterior anal canal. So this epithelium on the posterior anal canal splits, resulting in what is called as fissure of the anal canal. That is one mechanism, or repeated straining of diarrhea. Not only constipation and hard stool, but also diarrhea and dysentery also predisposes for this fissure formation because of repeated straining. The person has to visit bathroom number of times in a day. So repeatedly the epithelium is kept under stress and strain, so it breaks and results in fissure formation. The constipation as well as the diarrhea and dysentery both will at least predispose for development of the acute fissures. You can see in this picture, the hard stool is coming down. When the intra-abdominal rises, the pressure tries to push down the stool outwards. So the brunt falls more on the posterior anal canal and the epithelium here splits, forming the fissure in anal. And often it is chronic. It takes a long time for healing, or sometimes it persists without any healing. What is the reason for this chronicity of this ulcer? The perpetuation chronicity results from repeated trauma. Every day the person has to defecate, and that will disturb the ulcer. Lack of rest will not allow the ulcer to heal. The second one is muscle spasm, anal hypertonicity of the internal sphincter muscle. Third factor is vascular insufficiency in the midline. In the midline, the vascular supply is less, so less blood supply and ulcer will not heal. These three factors, repeated trauma, anal hypertonicity and vascular insufficiency, makes the ulcer or fissure chronic and takes a lot of time, more time for healing. Again, why posterior I said? Because of the strain that occurs on the posterior anal canal. This is more often posterior. And sometimes it is anterior, especially in women. In women who has undergone vaginal deliveries, the supporting muscle, the perineal body, perineal muscles are stretched and they are damaged and they no more support the anterior anal wall. So in such situations in women, multiparous women, you can see the anterior fissure also. This occurs in 10% of the cases. Sometimes you can see the fissures on the lateral wall away from the midline. The importance of this is these fissures, lateral fissures on the lateral wall of the anal canal, are not idiopathic or not primary. Remember, they are not primary. They are due to some specific disease. The fissures which are away from the midline cannot be primary, that is idiopathic. They do have certain causes. They are always secondary. So that you have to check and find out. They can be STD, they can be Chancre's ulcer, they can be a growth, they can be tuberculous ulcer, Crohn's disease. All these secondary cause of the fissure will present with a crack or ulcer on the lateral wall of the anal canal. So you must be cautious in dealing with the lateral fissures. So the specific causes where you can see lateral ulcers are like this. Incorrectly performed hemorrhoid surgery. If the person has undergone hemorrhoid surgery and a lot of skin has been removed, so the gap in between the skin bridges is large, so it takes a lot of time and it gets filled up with thin fibrous tissue, scar tissue. This scar tissue cannot tolerate the trauma of the defecation, so repeatedly it gives rise to a tear and acute fissures. That is calls for post-hemorrhoidectomy scar fissure, post-hemorrhoidectomy fissure because of the fibrotic tissue not tolerating the trauma. And inflammatory bowel disease, Crohn's disease, the ulcerative colitis may present with a fissure-like thing in the anal canal. Though the rectum is rarely involved in Crohn's disease, we do see Crohn's disease in the anal canal with multiple fissures and multiple fistula in anus. Of course, ulcerative colitis affects the rectum and anal canal more commonly than the Crohn's disease. Crohn's disease more often affects the small bowel and ileocecal junction. Ulcerative colitis affects the colon and rectum more commonly. That is usual, but we do see Crohn's disease affecting the anal canal with multiple fissures and multiple fistulas. Of course, venereal infection, the chancre can be seen. So chancre, genital chancre will be painless, and the lymph nodes are shorty, small and round lymph nodes will be seen. If this chancre is in the extragenital tissues like the lips, oral cavity, anal canal, etc., it will be more painful. Extragenital chancre will be more painful and the lymph nodes will be very large. So specific cause has to be identified when you see the fissure outside the midline. So regarding the site of the fissure, more commonly it is seen midline posteriorly, next midline anteriorly, and in the lateral wall also you can see. The pathology of the fissure, acute fissures are just a tear. Nothing more can be seen there. A tear will be seen, a fresh one, which is very painful. When it has become chronic, it evolves into a well-defined ulcer. The acute fissure evolves into a well-defined ulcer. The upper end of this ulcer, which is cano shape, the upper end of the ulcer extends up to the dentate line to the external anal opening. Because it occurs in the sensitive anoderm, pain is a prominent fissure. It is very painful, especially the acute fissures. The differences between acute and chronic fissures are: acute fissure is a deep tear in the anoderm. Little induration of the edges is seen. Because it is acute and short duration, the induration has not yet developed, so it will be soft to feel, but the sphincter will be spastic. The internal sphincter will be spastic and hard. Whereas the chronic fissure has evolved into a definite ulcer, which is cano shape, has got indurated edges. The base of the ulcer is either scar tissue or you can feel the internal sphincter muscle in the base. At the upper end of the ulcer, you see a hypertrophied anal papilla. These are the skin folds. rudimentary skin folds present at the junction at the dentate line where the proctodium and the post-allantoid canal gut has fused together. There are skin remnants present at the dentate line. So one of these hypertrophied anal papilla becomes larger in size and guards the upper end of the fissure. In the lower end, you can see another skin fold which is called as sentinel pile. Upper end hypertrophied papilla can be seen. Lower end you can see the sentinel pile. So this is the typical appearance of the anal fissure, chronic anal fissure. Whenever the fissure is not healing for a long time, though it becomes chronic, usually slowly it gets healed. When it refuses to heal for a long time, you must always think of the specific causes like granulomatous infections, tuberculosis, Crohn's disease, syphilis, etc. must be, and tumors must be ruled out. The pain will be lesser in such fissures than appearance of the lesion. When you examine the lesion, it appears more severe, but the person complains of little pain. That means pain is less than the appearance of the lesion. In such circumstances, you must suspect some specific pathology, try to do the appropriate investigations to identify the cause. This is the appearance of the fissure. In the left lateral position, Singh's position, when you gently separate the buttocks, you can see the fissure or at least lower end of the fissure. This is the fissurous part, the tear in the epithelium. This is the sentinel pile. You can see the tear in the fissure, anal canal. This is the lower end of the fissure. In acute circumstances, when you cannot conduct the digital rectal examination fully, depending on the symptomatology, if you gently separate the buttocks, you can see the lower end of the fissure. You can treat him with analgesic and antibiotics for a few days. When the pain comes down, you can examine him completely. Coming to the clinical features, this is most often seen in young persons, young patients, though it can be seen at any age. Fissure can be seen in infants also, mainly because of the loose motions or the diarrhea. The infant suffers more often. So this fissure, when it occurs in children and infants, it may lead to acquired type of megacolon also. Megacolon is congenital, most often seen in infants, with non-functioning segment of the rectum, result in obstruction and distension of the proximal colon. That also can happen if a child develops a fissure where because of pain, because of spasm, the anal canal is closed. It can lead to dilated upper tract and acquired megacolon. This can also be seen in elderly people, but more rarely you can see. You see a fissure in elderly people, you must suspect either malignancy or perineal descent because of the lax perineal muscles. Men and women are affected equally, and anterior fissures are commonly seen in women in 10% of the cases. So anterior fissures are seen in 10%, more commonly in women. The symptoms the patient complains of in acute anal fissures, pain is the symptom. Pain is the symptom. person has to undergo the RTL, the difficulty, every day early in the morning. And the pain is so severe that it makes him to rush to the hospital. This is the one condition, painful anal condition, which compels the person to the hospital. He cannot bear the pain every day. Severe pain will be there with defecation. It resolves after a variable time. It will be there for an hour or two, only to recur at the next evacuation. Once it subsides, the remaining rest of the day, there will not be any pain. He will be very comfortable. But again, the next morning, he has to suffer the same type of pain. It will be associated with loss of blood, passage of fresh blood. When the ulcer is disturbed, it bleeds. And this bleeding will not be coming out drop by drop as that happens in hemorrhoids. In hemorrhoids, when the person tries to defecate, there will be a splash of blood on the bedpan. Here it is not like that. The stool mass will have a reddish mark on one side, indicating there is little bleeding on that side. Or if the person cleans the tissue, there will be stain on the tissue. Cleans with the hands, there will be a mark on the hands. Little bleeding. So bleeding is not the major complaint. Pain is the main complaint for acute anal fissures. In chronic fissure, the pain comes down, pain will be little. There may or may not be bleeding, but other symptomatology will arise, like itching, which is secondary to irritation from the sentinel tag. So hypertrophied papilla and sentinel tag will develop in chronic fissures. They will not allow the perfect closure of the anal canal in the resting condition. So there will be a little ooze from the anal canal, spoiling the perianal skin. And because of sentinel tag, the perianal skin will not be dried automatically. So moistness of the perianal skin will be there that can irritate the skin and cause itching. So the additional symptom of perianal itching will develop in people with chronic fissures. A discharge can happen either from the ulcer or from associated intersphincteric fistula. A complex type of fissures will be associated with anal gland infection and subcutaneous fistulas. So a fissure with fistula or infection is called as a complex fissure. So in such cases, there will be discharge perianal. So in chronic cases, additional features of itching and discharge will arise, apart from the pain and bleeding. Coming to the signs, in acute situation, it is difficult to examine the patient. He will not allow you. Only lower end can be demonstrated with gentle separating the buttocks. You can visualize the lower end of the fissure to make you certain about the diagnosis and start the treatment. Never forcibly do the rectal examination in acute situations. You treat him for some days, then you do the proper digital examination later on. Chronic fissures. When you do the digital rectal examination, you can feel a gutter in the anal canal, in the wall of the anal canal. Gutter can be felt. The indurated edges of the ulcer can be felt. And you can feel a hypertrophied anal tag at the upper end. And of course, you can see the sentinel pad in the lower down. So you can definitely feel the well-formed indurated crater or the ulcer in the anal canal with indurated edges and tags on either side of the ulcer. So when to suspect the specific causes? Routinely, when you see when the person gives history suggestive of fissure, we definitely examine the posterior midline and find the fissure. If not, we will look at the anterior region and find a fissure. In these two situations, if you do not see the fissure, and if you see the fissure in the lateral wall, you must suspect the specific cause. Some cause is there for the occurrence of the fissure. So you must suspect the specific etiology when the fissure is away from the midline and when it has got atypical features. No induration, undermined edges, or more induration beyond the ulcer. Such atypical features are there. You must always examine the fissure completely. If the person is not allowing, you examine him under anesthesia. Give him under anesthesia. Then you examine properly and take a biopsy from the edge of the ulcer and send the discharge for culture and sensitivity. So in atypical locations, with atypical features, never neglect it. Even if you can take the help of the anesthetist and examine it completely, take a biopsy and culture. This is all to be done to see whether there is any specific etiology. If it is tuberculous, it will not heal unless you give him anti-tuberculous therapy. If it is anal carcinoma, it will never heal spontaneously. You have to do surgical excision and you have to give radiotherapy or chemotherapy. And if you neglect the malignancy for a long time, the operable carcinoma may become inoperable. So that is the danger of neglecting the fissure. So any fissure which is suspicious must be thoroughly investigated. Some specific causes of the fissures are Crohn's disease, already we told. You can see tuberculosis with undermined ulcers, sexually transmitted ulcers like syphilis, chlamydia, chancroid, lymphogranuloma venereum, herpes simplex virus, cytomegalovirus. Tumors like Kaposi sarcoma, B-cell lymphoma can occur, HIV-related ulcers, and finally squamous cell carcinoma. The lymphomas can develop cutaneous metastasis. They spread to the skin and form localized nodules. So especially in old people where the lymphoma is common, when there is undiagnosed cutaneous nodule, you must suspect the lymphoma and do the peripheral blood smear and send the tissue for biopsy after excision. So lymphoma can occur in the skin also. The most important one is the squamous cell carcinoma, which presents typically with cauliflower-like ulcer, everted edges, and indurated bases. The differential diagnosis of this is the main one is carcinoma canal, where there will not be much pain because it is atypical. There will not be pain, and the induration will be more. The biopsy proves it to be the malignancy. And when you see multiple fissures all around the circumference of the anal canal, you must suspect general skin diseases like psoriasis, lichen planus, itching, etc., candidiasis. Or it can be due to scratching. Person is suffering with perianal itching because of so many reasons, especially in diabetics. Scratching may result in multiple fissures. Inflammatory bowel disease, the Crohn's and the ulcerative colitis can present as multiple fissures. STDs and unnatural sexual practices, all these things will result in more number of fissures or ulcers along the circumference. Another differential diagnosis is tuberculosis. You can see an ulcer with undermined edges, thin livid margins, no induration, and watery discharge. So you must suspect tuberculosis in some cases. Proctology of Figax. This is a functional condition. The symptomatology will be very, very similar to the fissure, but when you examine, you do not find the fissure anywhere, not in the midline, not on the lateral walls. The symptomatology of perineal pain will be very similar to that of the fissure in abdomen. This occurs especially in women, especially in anxious persons. So in such cases, you must suspect the proctology of Figax, and you have to do some electromyographic records to confirm the diagnosis. So the levator ani muscle or perineal muscles, puborectalis muscle, is in spasm. This is a functional disorder. Summary of the fissure: it can be acute or chronic. Ischemic ulcer in the midline of the anal canal. Because of ischemia, it occurs more often in the midline. Ectopic site suggests a more sinister cause. Symptoms are pain or defecation, night with bleeding, mucus discharge. So the diagnosis of anal fissure, acute or chronic anal fissure, is very straightforward. Simple inspection, proper inspection under good light, depending on the symptomatology, will make you to diagnose the condition. The one you have to do is, you must rule out the dangerous causes of the anal fissure, like malignancy. That's what you have to do. Because the diagnosis is straightforward, don't go blindly with the diagnosis. You have to first confirm the diagnosis and rule out the secondary causes. That you have to do. The conservative management result in the healing of almost all acute fissures. Acute fissures without induration, just a tear, will heal with conservative management. And majority of the chronic fissures also heal with conservative management, but they take a little more time than the acute fissures. The principle of the treatment. In the beginning I said, though it is simply a crack in the epithelium, where it is present, the circumstances where it is present are different. That's why it needs a different type of management. The principle of treatment is, the spasm of the sphincter causes the pain. Pain is the ultimate symptom that brings the person to the hospital. And lack of rest to the ulcer prevents healing of the ulcer. Every day the person is training and disturbing the ulcer and stretching the ulcer. How can the ulcer heal? It will never heal. These are the two important pathologies that causes the symptoms of the fissure. So you have to understand them and deal with them. You relax the muscle somehow and relieve the pain. Avoid strain and Regular bowels rest the ulcer. If you avoid the strain, see that the person do not strain much every day and make him to get the habit of regular bowels every day once or twice. If you regularize these bowel movements and give rest to the sphincter and the ulcer, they will heal. So our treatment must aim at two things: relaxing the internal sphincter muscle and regularizing the bowel habits. The goal of the treatment is to relax the sphincter. Somehow you relax the sphincter by any means, conservative, dilatation, surgery, whatever it may be, you are trying to relax the sphincter and give some rest to the ulcer so that it heals. So what to do to achieve this goal, we will see now. The conservative management of the fissure. The first thing is normalization of bowel habits. Make the passage of stool as less traumatic as possible. Make the stool softer. Make the stool bulkier. Make it more slippery, so that without straining much, the person will defecate every day. Normalize the bowel habits. If he is constipated, treat the constipation. If he is dysenteric, treat the dysentery. See that normal soft stool passes. To achieve this, simple and helpful measures are fiber diet to bulk up the stool. Increase the amount of fiber in the diet. Ask him to take a lot of vegetables, leafy vegetables and other vegetables which contains fiber. If necessary, give him stool softeners, some syrups which will make the stool soft and slippery. Ask him to take adequate water intake, especially in summer. You must take adequate water so that the stool will not be hardened up in the colon and the rectum. Then, warm baths called as SIDS baths. Ask the patient to take a wide tub, put some lukewarm water and put some antiseptic like Dettol or Betadine or some salt, and ask him to sit in this water. It is called as SIDS bath. SIDS bath means hip bath, only immersing the buttock regions for 5 to 10 minutes. So this will comfort the person. The warmth will decrease the pain, warmth will relax the muscle, and the antiseptic will clean the ulcer. So this will help in the healing of the ulcers. Then you can give topical local anesthetics to relieve pain. Number of creams are available containing the xylocaine, containing the corticosteroids, containing the zinc oxide paste, all these things. Skin sootheners, which will decrease the pain and decrease the edema of the edges of the ulcer. And of course, you can give anal dilators. These are metal instruments or glass instruments which, well lubricated, can be passed into the anal canal by the patient himself once or twice in a day, which will stretch the muscle gently and try to relax the muscle. So these are the things that you have to do in conservative management. Along with this, you may have to give some certain medications. The examples of stool softeners what we use routinely are the clemafene, which contains sodium picosulfate, a laxative, a liquid paraffin, and milk of magnesia. All these things are laxatives which will waterize, liquefy the stool and try to pass it freely. Then you can give lactose also. You can give polyethylene glycol, or you can give Ispagula husk. Ispagula husk is a powdered form of fiber. It is available as a powder. You can mix it with water and take at the bedtime, which will swell up the stool mass, makes it soft, and makes it easy to pass. Along with the foresaid general features, you may have to give specific agents, pharmacological agents, which will relax the internal sphincter. Majority of these things are nitric oxide donors. Nitric oxide is a neurotransmitter. I said NANC fibers will release nitric oxide in the last class. If this is applied locally, it will try to relax the internal sphincter muscle and abolish the spasm. By reducing the spasm, the pain is relieved, and because it is also a smooth muscle relaxant of the arteries will dilate and improve the blood supply, taking care of the ischemic element also. The muscle is relaxed, the arteries are dilated, so both the things will help to heal the ulcer. The agents commonly we use are the glyceryl trinitrate, GTN 0.2%, 4 times a day to the alarm margin. You might have heard this glyceryl trinate in your cardiology classes, where it is used to abolish the spasm of the coronary arteries, where it is infused intravenously in treating hypertensive crisis. And the blood pressure is so high, the glyceryl trinitrate infusion is given, which will instantaneously dilate all the arterioles and arteries, decrease the blood pressure. So the same can be given here in the form of an ointment locally, which will try to relax the internal sphincter muscle. And the only disadvantage with this is the severe headache. Some people will suffer with it. When it is absorbed into the system, it causes severe headaches. And another agent is diltiazem 2% applied twice daily. These two are the nitric oxide donors which are used locally to relieve the spasm of the muscle. So this part forms a part of the conservative management. And another one is, if the pain is not relieved with this conservative management, you may try the Botox injection, which is a powerful smooth muscle paralyzer. This does not relax the muscle, it completely paralyzes the muscle. Muscle paralysis. It is usually a toxin which is produced by the Clostridium botulinum. When it is in sufficient quantities released into the body, it kills the persons. It is a powerful toxin, botulinum. But it can be under controlled situations, it can be used therapeutically also. Inject the local Botox injection 10 to 100 units into the sphincter muscle to paralyze it. So this paralysis will stay there for a long time. Of course, the muscle will recover spontaneously. It takes a long time, at least 6 months for recovery. So by that time, the ulcer will be healed. So if the regular conservative treatments are not helpful, you can go for local Botox injections, which may help you to heal the ulcer. The next thing is, before going in for surgical measures, via media you can try the anal dilator therapy. So you can see this anal dilator. You can apply gelatin here, lubricant, and the person sitting in a squatting position, he can pass this dilator by himself and keep it there for 1 or 2 minutes and remove it. If you do this every day, the sphincter muscle will be gradually stretched and it will be relaxed, avoiding the pain. Graduated anal dilators can be passed to stretch the sphincter. They are not helpful in acute cases because of pain. Acute fissure you should not advise. In acute cases, they will not allow the digital examination even. So you cannot pass the dilators. Wait for some time, then you can do. They are used along with the conservative management. The response is not good with only medicines. You can try the dilator therapy along with conservative management. You can use them in chronic cases where there is some amount of muscle spasm, and post-hemorrhoidectomy to prevent stenosis. If there is a difficult hemorrhoidectomy with larger size ulcers, lot of spasm of the muscles, where we expect the anal canal stenosis afterwards, in such case after 2 weeks or 3 weeks post-op, you can suggest the anal dilator therapy to prevent the incidence of anal canal stenosis. So under certain circumstances, you can use this anal dilator therapy, which is very simple, and patient himself can do it. But the problem is non-compliance. Patient will not be compliant, for he will do it for 3 or 4 days and keep it away. That's the main problem with the anal dilator therapy. Then finally the operative treatment. If the conservative treatment fails, the ulcer is not healing, no symptomatic relief, or acute fissure is there with severe pain, patient is not tolerating, difficult to pass stools, where there is urgent need of relief of pain. Then in chronic fissures with fibrosis, where you do not expect the ulcer to heal conservatively, and where there are skin tags and mucous polyps which need excision anyway, in such circumstances, you can advise operative treatment. Operative treatment. This is done to relax, to stretch, or to cut the internal sphincter. You can do procedures to relax the muscle, to stretch the muscle, or you can cut the muscle by operative procedures. So what are these things that are done? We will know now. The common thing, common operative minor operation done to relax the internal sphincter muscle is manual anal dilatation. We will be calling it as MAD. This is a common surgery that is done, that will be there in the surgical list, in the operating list. MAD will be done for fissure cases. It is a forcible manual sphincter dilatation called as MAD or Lord's procedure. Lord's procedure. Lord's operation will be done. Lord's plication operation will be done for hydroseek. Here, Lord's stretching of the sphincter. Lord's procedure. This can be done under regional anesthesia or general anesthesia. You can give short general anesthesia without intubating. You can do the MAD, or you can give regional anesthesia, low spinal anesthesia, or caudal block can be given to do this stretching of the sphincter. The problem with this stretching is the sphincter is stretched in uncontrolled fashion. Somebody can do it rightly, somebody can do it more forcefully. So there is no control how much to stretch the sphincter, how much to pull it like that. So the sphincter is stretched in uncontrolled fashion, which results in disruption of the muscle at multiple sites. Why we are doing this MAD? To relieve the pain, severe pain to the person. After the procedure, after recovery from anesthesia, The patient must be comfortable. He should not complain of pain, previous pain. If he is again complaining of pain, means that you have stretched the sphincter uncontrolledly, and you have damaged the sphincter. Because cause breaks in the muscle fibers, leading to a lot of postoperative edema and recurrence of the pain. That is a useless thing. Patient came for relief of pain, and you are giving him another type of pains. So what are the use of it? So the patient is comfortable means you have stretched it correctly. Still pain is present, different type of pain is there, inflammatory pain is there, means you have stretched the sphincter wrongly. Because of this multiple stretching of the sphincter, damaging the sphincter at multiple sites, there is some risk of incontinence. Pain is there, patient becomes incontinent. Because of these untoward effects of this man, because of the side effects, it has become unpopular. But still, it is if you do it correctly, it is a very good procedure which gives immediate relief to the person.
నువ్వు అనుకునేది వేరే, నువ్వు ఎక్కువ నీ దృష్టిలో వేరే, నా దృష్టిలో వేరే. ఇప్పుడు షార్జాలో మజాజ్ పార్క్ లో మజాజ్ పార్కే కాదు, బయట అయినా సర్కిల్స్ రౌండ్ అబౌట్ ప్రతి మొత్తం కూలే ఉంటుంది. అలా ఎలా రావడం? ఎలా అంటే దండిగా
How to do it correctly? The manual anal dilatation. The stretching of the sphincter should be done carefully in controlled fashion. Up to 4 fingers size is enough. Some people say 4 to 8 fingers. 8 fingers will be too much. It will stretch and tear the muscle. So 4 fingers is enough. The last method of doing this like this. The well lubricated finger is kept in the anal canal. 1 finger for 1 minute. Wait for 1 minute. Introduce 2 fingers. Wait for 2 minutes. 3 fingers for 3 minutes. And 4 fingers for 4 minutes. It will take 10 minutes to stretch the sphincter in a controlled fashion without damaging that. And this is done for hypertonic sphincters in young people. The MAD must be done when there is definite muscle spasm, sphincter spasm. Don't advise this MAD when there is no muscle spasm and in old people where the muscles are already lax. The old man develops fissure in ano, don't advise MAD. Already the muscles are weak and you are damaging the sphincter further, leading to incontinence. There you can do conservative measures, some ointments, etc., which will heal the ulcer. So if you do it correctly, this is a very good procedure to relieve the pain of the acute fissure. Then you can cut the sphincter. Will there not be any incontinence if you cut the sphincter? There will be, but it will be healed. It will be disappear spontaneously. The supersphincter, the anorectal ring, is there at the higher level, which will take care of the continent mechanism. You can cut the lower one-third of the internal sphincter without any risk of incontinence. You can cut the lower sphincter below the level of the dentate line, never above it. If you follow these two principles, lower one-third or at least below the level of the dentate line, there will not be incontinence. It will be taken care of by the anorectal ring. So you can safely cut the internal sphincter to relax it. Some people will do this internal sphincterotomy routinely instead of MAD for dealing with the anal fissure. This may be appropriate in Western populations where their habit of visiting the bathroom is once in a week or so, because they consume less fiber containing diets. In countries where people consume a lot of fiber, like in India or in Africa, where they defecate once or twice in a day, frequently, more frequently, this procedure, cutting of the sphincter, is not useful and it will be a little cumbersome also. Cutting of this sphincter will lead to, even though it will not cause incontinence to the feces, it will cause incontinence to the flatus. When such a person passes flatus, it will cause a lot of sound, disturbing sound, annoying sound. So for these reasons, we feel the sphincterotomy is not suitable for Indian populations. You can stretch it simply, that will be sufficient. Where to cut the sphincter? You can directly cut the sphincter where you see it in the base of the ulcer. That is dorsal or posterior sphincterotomy. In the posterior midline, where the muscle is exposed in the ulcer, you can cut it. Or you can cut it laterally also, right lateral or left lateral, called as lateral sphincterotomy. Dorsal sphincterotomy takes a lot of time for healing because it is in the midline. Every time the person walks, the ulcer is disturbed, the ulcer is moving, lack of rest, so it takes a lot of time. So people have modified this and is cutting the sphincter laterally to relax it. The division of exposed fibers of the internal sphincter in the fissure base is called as dorsal or posterior sphincterotomy. It prolongs healing, and there is passive anal leakage because of the keyhole gutter deformity that results when you cut the sphincter. There will be a gutter in the posterior side through which the flatus and little amount of fecal matter fluid will seep outside. This is indicated when it is associated with intersphincteric fistula. The fistula is associated with it, or very chronic fissure and recurrent fissures, we can adopt the posterior or dorsal sphincterotomy. The most commonly done is lateral sphincterotomy. The sphincter is divided away from the fissure itself, either in the right side or the left side. It can be done by open method or closed method. Under local, regional, or general anesthesia, any type of anesthesia can be suitable for this. The patient is kept in lithotomy position or prone jackknife position. Lithotomy position in European countries, Asian countries, we follow this lithotomy position, dorsal position. In America, they follow the prone jackknife position, prone position. The distal part of the internal sphincter is palpated in the intersphincteric groove, and it is stretched by putting a bivalved speculum so that the muscle is stretched, made taut, easy to identify the lower end of the sphincter. Then you cut it. In the closed method, A small nick is given in the intersphincteric groove. The mucosa on the medial side, the external sphincter on the lateral side are separated by blunt dissection, and you can see the internal sphincter clearly. Take a scissor, put your finger at the dentate line as a guide, then cut the sphincter with the scissors. Keep pressure for some time to prevent the bleeding. Once the hemostasis is achieved, you close the wound with absorbable catheter. So that is lateral sphincterotomy closed method. The alternative form of closed method is using a tenotomy knife or number 11 blade. Here no need to cut the skin, no need to dissect the intersphincteric plane. You palpate, stretch the sphincter, you palpate the sphincter and pass the number 11 blade parallel to the internal sphincter. When you have passed up to 1/3 of the sphincter, you turn the blade so that the cutting edge is towards the muscle. Gently cut the muscle without piercing the mucosa, keeping your finger as the guide. And take the blade out and put pressure for some time. Here you have not opened the skin, so no need for suturing also. This is an alternative method. And if you have got a tenotomy knife where it is used to cut the tendons by orthopedic people, you can use this tenotomy knife also to cut the lower 1/3 of the internal sphincter. That is closed method, alternative method of closed sphincterotomy. Or you can do it open method. Here, the anoderm is divided longitudinally in the lumen of the anal canal. You identify and separate the internal sphincter muscle, divide the sphincter, then close the wound with absorbable cartilage. Here, the muscle is exposed by an incision in the skin. Under vision, the muscle is identified and separated, and the muscle is divided. Wound is closed. So either way, open method is very simple, closed method is simple, and you can do the open method also. This relaxes the sphincter temporarily, and when the fibrous tissue forms, the cut ends of the muscle will fuse together. Again, the entire circumference of the sphincter is restored. For this to happen, it will take some time. By that time, the fissure might have healed completely. The complications resulting after sphincterotomy: hemorrhage, hematoma, bruising, and perianal abscess and fistula. Incontinence is seen in up to 30% of the people. And another new procedure is, without risk of incontinence, is anal advancement flap. The local flap is raised in the perianal skin. After excising the sphincter fissure, chronic fissure, you can advance this skin flap into the anal canal and close the defect. This is the recent type of treatment without the risk of incontinence. This is advancement flap. Perianal skin is raised and sutured into the anal canal. This is a functional aspect of the perianal pain. Thank you. Stop sharing. Recording model.
ఎన్ని మీటింగ్ పైన ఇది వస్తుందంట. రావాలా ఎందుకు రాదు? అది పోతున్నా